Hello everybody and welcome to this Cardiology Mentorship program. My name is Dr. Messaoudi Usra. I am a cardiologist associate professor from Tunisia. We are going to talk today in this first session of adult congenital heart disease about left to right shunts in adulthood, and we will try to have an overview on the most common shunt lesions. To begin, let's talk about physiopathology. We know all that with normal heart cardiac anatomy, there is a complete septation of oxygenated and deoxygenated blood. The term of shunt refers to an abnormal connection allowing oxygenated pulmonary venous blood to return directly to the lungs rather than being pumped to the body, and depending on the relationship to tricuspid valve, the shunt can be classified as a pre-tricuspid shunt or a post-tricuspid shunt. The example of pre-tricuspid shunt is the atrial septal defect, and this type of shunts leads to a volume overload on the right-sided cardiac structure, the right atrium and the right ventricle. However, post-tricuspid shunt is responsible for an enlargement on the main pulmonary artery, but mainly on the left atrium and left ventricle, as well as an increase in pulmonary vascular markings. In fact, these physiopathological elements are crucial to understand in order to explain our attitude towards diagnosis and many therapeutic indications. Let's begin with the most common pre-tricuspid shunt, that means the atrial septal defect or ACHD. It represents 80% to 13% of all congenital heart disease. ACHD can remain undiagnosed until adulthood, and it is the most common congenital heart disease diagnosed in adulthood, accounting for 25 to 30%. According to the location of the defect, we distinguish 4 types of atrial septal defect. It can be a sinus venous defect located which occur near the entry of the superior or inferior vena cava. It accounts for 5 to 6% of ASDs. This type of defect is associated with anomalous pulmonary venous return. The superior is more frequent than the inferior type. The most type is secundum atrial septal defects, and this is the more frequent one, accounting for 80% of ASDs, and are located within the fossa ovalis. The vice closure is the treatment of choice when feasible. Type 3 is premium ASDs, which accounts for 15% of ASDs and occur adjacent to the atrioventricular valves. Associated AV valve abnormalities are common, and surgical intervention is the accepted treatment. And the more exceptional one is what we call coronary sinus defects, which accounts for less than 1% of ASDs and occur because of unroofing of the tissue separating the coronary sinus from the left atrium. They are associated with persistent left superior vena cava and are treated surgically. So, we will focus mainly here on the secundum atrial septal defects, which is the most prevalent one. What about clinical presentation and natural history of ASD? We should know that patients frequently remain asymptomatic until adulthood. However, the majority develop symptoms beyond the 4th decade. What type of symptoms? It can be a reduction in functional capacity and exertional shortness of breath and palpitations because of supraventricular tachyarrhythmias, and less frequently pulmonary infections and right heart failure. So, in case of clinical suspicion of ASD, the first exam, the first lane and the more important exam remains echocardiography. Echocardiography should precise the size and the location of defect according to the anatomy, measurement of all rims of the defect, the aortic, the vena cava rims, superior, posterior, inferior, and atrioventricular valve rims. And here we emphasize on the role of transesophageal echocardiography, which should be done systematically in adults for a complete evaluation of ASD. Moreover, echocardiography should assess the right ventricular chamber size and give an estimation of the right ventricular pressures. In fact, right ventricle volume overload may be the first unexpected finding in a patient with previously undiagnosed ASD, and this is the key which characterize the hemodynamic relevance of the defect. Here are some examples of transthoracic echocardiography showing an ASD, an ostium secundum ASD, from the parasternal short axis view. And here we have color Doppler with left to right shunt. Same thing here with this defect and with the left to right shunt on color Doppler. Now, as with T2, we need multiple and sequential transesophageal views that should be used to completely and systematically evaluate the anterarterial septum, the size, the shape, and location of any arterial communication present, and mainly the relationship of the defect to its surrounding structures. Here, we have a summary of the key views using transesophageal echocardiography to assess the anterarterial septum and the surrounding structures. These views are the basal transverse, which can describe the superior vena cava, the superior aortic, and relation to the pulmonary veins. The four-chamber view, which describes the posterior and AV rims and the maximal ASD diameter, the short axis view, and the bicaval view. Here is an example of an ASD on transesophageal echocardiography. We see here one medium and one small ostium secundum ASD. This was confirmed and more precise using 3D transesophageal echocardiography, and this was confirmed by surgical when doing surgical repair. So we can have multiple ASD. Here we focus on the role of 3D imaging in providing a unique view of the anterarterial septum, and particular allowing foreign face viewing of the ASD with the surrounding structures for accurate determination of the ASD size, the ASD shape. Here, for example, a small round, here a larger round, a small oval, a large oval ASD defect. We said that echocardiography should precise the different rims of the ASD. We describe here, for example, on three-dimensional TO, we have an ostium secundum ASD with a mildly deficient aortic rim. There is no an aortic rim in this view. And for more information, I recommend you to have a look on this very interesting paper published on the Journal of the American Society of Echocardiography, which describes the different guidelines for the echocardiographic assessment of atrial septal defects according to the American Society of Echocardiography. So, we have the diagnosis, we have done all the measurements Is there a need for further investigations? Yes, we can use also cardiac magnetic resonance imaging, which has an important role in the imaging of ASD when additional information is required after echocardiography and provides accurate measures mainly of the right ventricle size and function, the location of pulmonary veins, and the quantification of the pulmonary to the systemic flow ratio, pulmonary flow and systemic flow. We can do also a diagnostic catheterization for adults, not for all adults, but that should be reserved for patients with pulmonary hypertension. That should be done. For patients also with left heart disease or older patients in which there are concerns for coronary artery disease. In fact, cardiac catheterization is required in case of non-invasive signs of pulmonary arterial pressure elevation, calculated as a systolic pulmonary arterial pressure more than 40 mm, or indirect signs. This is mandatory to determine the pulmonary vascular resistance. And according to the European Society of Cardiology guidelines, we need sometimes an exercise testing that should be performed in patients with pulmonary arterial hypertension to exclude desaturation, which may represent a contraindication for closing the defect. What about the treatment? We know that there is two options for treatment: device closure or surgery. Device closure has become the first choice for secondary defect closure, when feasible, based on the morphology that includes a structure diameter less than 38 mm, sufficient rim of 5 mm except towards the aorta, and this is the case in about 18% of patients, although it cannot be assumed to be zero. Several recent studies have reported no mortality. Serious complications have been observed in less than 1% of patients. For surgical repair, it has low mortality, less than 1% in patients without significant comorbidity, and good long-term outcome when performed early. That means during childhood or adolescence and in the absence of pulmonary hypertension. Although surgical repair can be performed with very low risk, even in the elderly, comorbidities that may affect operative risk need to be considered and then risk weighed against potential benefit. In fact, studies comparing surgery and catheter intervention have reported similar success rates and mortality, but morbidity was lower and hospital stays shorter with catheter intervention, while reintervention rate was slightly higher. In patients with impaired left ventricle function, systolic or diastolic, ASD closure may worsen the heart failure. Thus, these patients must be carefully evaluated and may require pre-interventional testing, balloon occlusion with reassessment of hemodynamics to decide between complete, fenestrated, or no closure, considering that an increase in filling pressure due to ASD closure may worsen symptoms and outcome. And in summary, these are the recommendations for arterial septal defect closure according to the European Society of Cardiology guidelines. So, we recommend closure of the defect in all patients with evidence of right ventricle volume overload and no pulmonary hypertension, and this regardless of symptoms. And this is a class 1B recommendation. The device closure must be the method of choice for secondum ASD closure when technically suitable. And for patients with pulmonary hypertension on non-invasive examination, that means on echocardiography, and with QP and QS more than 1.5, we should do a diagnostic catheter, and then we should calculate pulmonary vascular resistance. If pulmonary vascular resistance is less than 3 Wood units, it's class 1 for occlusion of the device. If it's between 3 and 5, we can, but it is class 2A. And for patients who have pulmonary vascular resistance more than 5 Wood units, we should give patient a targeted pulmonary arterial hypertension. If there is a decrease, it's a class 2B for AST closure with a fenestrated closure only. If no decrease of the pulmonary pressures despite targeted treatments, it's an absolute contraindication for AST closure. There are some other additional considerations when talking about adults, mainly exercise and sports. And there is no restrictions in asymptomatic patients before or after intervention without pulmonary hypertension, significant arrhythmias, or right ventricle dysfunction, limitation to low intensity recreational sports in pulmonary artery hypertension patients. In pregnant women, there is a low risk in patients without pulmonary hypertension, although there may be an increased risk of paradoxical embolism. Patients with precapillary pulmonary hypertension should be counseled against pregnancy. And atrial septal defect is not a disease with a high risk of infective endocarditis. However, we recommend infective endocarditis prophylaxis for 6 months after device closure. We should also know that patients with ASD are exposed to atrial arrhythmias, and in patients who undergo ASD closure after the age of 14 years, the prevalence of atrial arrhythmias is up to 40 to 60%, and the access to the left atrium may be restricted after device closure. Now we will move to the second type of the left to right shunt, and it is a post-tricuspid shunt. It's about ventricular septal defect or VSD. VSD are the most prevalent congenital cardiac anomaly in children and the second most common in adults after ASD. VSD is mostly diagnosed and when indicated treated before adulthood. And in the same way of ASD, we distinguish 4 locations of ventricular septal defects. It may be a doubly committed subarterial ventricular septal defect, a perimembranous ventricular septal defect, an inlet or atrioventricular septal defect, or a muscular ventricular septal defect. The most common one is perimembranous ventricular septal defect, accounting about 80% of all types. It's located in the membranous septum with possible extension into inlet, trabecular, or outlet septum adjacent to tricuspid and aortic valve. The second type is the muscular trabecular, up to 15 to 20%, completely surrounded by muscle, various locations, frequently multiple, with spontaneous closure particularly frequent. The other types are the outlet, with or without malignment of the outlet septum. It's called supracrestal, subarterial, subpulmonary, and fundibular canal, or doubly committed juxtaarterial, accounting for about 5%, located very near to the aortic valve, which can be associated with progressive aortic regurgitation due to the prolapse of the right aortic cusp and aneurysm of the sinus of Valsalva. And the last one is the LH or the AV canal ventricular septal defect type, which is located in the inlet of the ventricular septum immediately inferior to the AV valve apparatus. Is frequently associated with a common AV valve and may be associated with AV septal malignment and straddling of the tricuspid valve. Typically, this type of VSD occurs in Down syndrome. So, echocardiography also is the most important exam to precise anatomy, the left to right shunt, and the dimensions of the defect and mainly the left cardiac cavities. Here, for example, we see a perimembranous VSD with a left to right shunt on color Doppler with an enlargement of the right ventricle. So, in case of adults, there may be 5 situations with VSD. VSD may be operated on in childhood without residual VSD and no pulmonary hypertension. The second situation is that the VSD was operated on in childhood with residual VSD and the residual shunt size determines the degree of left ventricle volume overload and the development of a pulmonary hypertension. It may be a small VSD with insignificant left to right shunt without left ventricle volume overload or pulmonary hypertension. That's what we call restrictive VSD, which wasn't considered for surgery in childhood. We can have a VSD with left to right shunt with a pulmonary hypertension of various degrees and various degrees of left ventricle volume overload, which is more rare. And the final situation is a VSD with right to left shunt, what we call an Eisenmenger syndrome with a large non-restrictive VSD which wasn't treated correctly. So, independently of the hemodynamic aspects of VSD, we can have other problems in adults in relation to VSD. Most frequent one is progressive aortic regurgitation and formation of a sinus of Valsalva aneurysm in relation to an outlet VSD, less commonly perimembranous, with a Venturi effect that causes a prolapse of the right coronary or non-coronary cusp of the aortic valve. The second problem may be arrhythmias, but this is less frequent than in other forms of congenital heart disease. We may have a complete heart block, mainly for patients operated in childhood. We can have late left ventricle dysfunction and heart failure and endocarditis. So, how can we treat VSD in an adult? Patients eligible for VSD closure at adult age are rare, and most patients have either small VSDs with insignificant shunt or have already developed pulmonary hypertension. The latter must be evaluated with particular caution. Patients with shunt closure and persistent progressive pulmonary arterial hypertension appear to have a particularly poor outcome. So, according to the European Society of Cardiology, we should ask first question, is there or no left ventricle volume overload? If yes, we should evaluate pulmonary arterial pressure. If there is a hypertension, pulmonary arterial hypertension, we should complete with a catheterism, so to evaluate pulmonary vascular resistance. If less than 3 Wood units, this is an indication for closure of the defect. If yes, we should see if this pulmonary vascular resistance is less than 5 Wood units or more, etc. If there is no hemodynamic problem or pulmonary hypertension, we should ask the question: is the VSD very near to the aortic valve, and is there or no a prolapse or a aortic regurgitation? If yes, this is an indication for closure with a class 2A. Now, let's move to the third type of shunt, left to right shunt in adults. It is also a post-tricuspid shunt. It's the patent ductus arteriosus. It is the persistence of communication between the proximal left pulmonary artery and the descending aorta just distal to the left subclavian artery. It can be associated with a variety of congenital heart disease lesions. However, in adults, it is usually an isolated findings. PDA originally results in left to right shunt and left ventricle and left atrium volume overload. In moderate and large PDA, pulmonary arterial pressure is elevated. In patients who reach adulthood with a moderate PDA, either left ventricle volume overload or pulmonary arterial hypertension may be predominant, and adult patients with a large PDA have in general developed esophageal physiopathology. Echocardiography is also the key diagnostic technique and provides the diagnosis that may be quite difficult in patients with esophageal physiology. It provides also the degree of left ventricle volume overload, pulmonary arterial pressure, pulmonary artery size, and right heart changes. Here, this is an example of PDA in the three-finger view, confirmed with color Doppler with a left to right shunt and with a continuous wave on continuous Doppler. As for the other left shunts, cardiac catheterization is required in the case of non-invasive signs of pulmonary arterial pressure elevation, calculated as a systolic pulmonary arterial pressure more than 40 mm or indirect signs, and this is mandatory to determine pulmonary vascular resistance. Exercise testing should be also performed in patients with pulmonary arterial hypertension to exclude desaturation of lower limbs, and this is according to the European Society of Cardiology guidelines. What about the treatment? Device closure is the method of choice, even if cardiac operations are indicated due to another concomitant cardiac lesions and can be successfully performed in the vast majority of adults with a very low complication rate. Surgery is reserved for the rare patients with a DAC too large for device closure or with unsuitable anatomy such as aneurysm formation. And here we have a summary of the European Society of Cardiology guidelines according to the indications of the closure. We also may ask if there is or no a left ventricle volume overload, and if there is or no an elevation in pulmonary arterial hypertension and then in pulmonary vascular resistance. So, to summarize, after seeing these three types of most frequent left to right shunts among adults, there are guidelines to manage these shunts, and according to the European Society of Cardiology and the American Society of Cardiology, both sets of guidelines depend on the degree of shunting and the impact on cardiac chamber for indication of the defect closure, and they depend on the evidence of pulmonary vascular disease and pulmonary hypertension for contraindication. There are some differences between European and American guidelines. In fact, American guidelines focus on the ratio of pulmonary to systemic resistance or pressure, whereas the European Society of Cardiology guidelines focus on inindexed pulmonary vascular resistance. And thank you for your attention.